So thank you guys for coming to talk about shared decision making as the very last didactic. And we got a very nice compliment from the program committee. Apparently they're talking about how do you keep people here on Friday afternoon, and they said, well, we put all of our best didactics last. I kid you not, that's what they said. So no, I didn't make that up. That's true. They did. They said I had a meeting just now, and that's what they said. Didn't make me feel any better. But so we're going to be talking about shared decision making. We're all going to introduce ourselves, and then we're going to figure out who you guys are. But my name's Elizabeth Schoenfeld, and I'm coming from Bay State Medical Center. And you have a okay.
Well, I can go next. I'm Esther Chen. I'm from UCSF. I'm the educator on this panel, and not a shared decision making expert like everybody else.
Hi, I'm Marc Probst from Mount Sinai in New York City. I do a little bit of shared decision-making research, and I also really enjoyed doing it in the ED.
I'm Hemal Kanzaria. I'm also at UCSF, and I do a little bit of research on shared decision-making as well as on social determinants of health, and I'm happy to be here.
I'm Erik Hess. Many of you know me. For those who don't, I'm at the University of Alabama at Birmingham. With this rowdy crew here. I've been doing shared decision-making research for about the last 10 years. And now I'm integrating that with how does that work within the context of social determinants of health. So it's exciting for me, and I'm ready for this group to take it off.
So it would be great, actually, just because it's a pretty small group, to be, informal. It'd be great to hear, a little bit about who you are, where you are in your training, where you're at, and then also sort of what you wanted to get out of this workshop.
I'm Andrew Meltzer at GW. I'm the research director there. I do clinical research, and mostly on abdominal pain, GI emergencies. We have done 2 prior shared decision-making studies. We've got a 3rd one starting this summer, and interested in learning from the experts. So.
Hi, I'm Kevin Manjal from Mount Sinai. I study EMS innovations.
Hi, I'm Matt Reed. I'm the research director in Edinburgh in the UK, and I'm here to learn about more shared decision making because I don't do anything about it, and we don't do it in our own department. So,
I'm Erin Schuffelberger, one of the 2nd-year residents at UAB.
I'm Sherelle Hicks. I'm one of the 3rd-year residents at UAB.
I'm Lauren Walter. I'm APD and clinical researcher at UAB.
I'm David Page. I work clinically in the ER in the medical ICU, and I'm just starting a career in clinical research as well. And apparently I'm very loud.
I'm Max Thompson. I'm at UAB as well.
I'm Neil McDonald. I'm at UAB as well. I'm a 2nd-year resident.
I'm Vivetta Lobo. I'm not from UAB. I'm from Stanford. I'm a faculty member there. I've been there for many years. The reason I wear many hats, I'm an ultrasound director there, but I also am the medical director for our Patient and Family Advisory Council that we run there for many years, and that's kind of what brought me here.
I'm Michelle Lynn. I'm at Mount Sinai. I'm a health services researcher moving into the patient-reported outcome measure space. I'm actually really interested not just as a researcher but also as an educator and how I can better teach shared decision-making, and also ensuring that it actually is shared decision-making, because I often get the sense that someone believes that shared decision-making happened, but there was a lot that was missing.
I'm kind of curious for the faculty who are here. Thank you for telling us that you were interested in how to better teach shared decision making. For some of the other faculty here, is it as a research topic? Is it as an implementation question? And that's why you're here. Could you guys elaborate a little bit?
Thank you. Yeah, for me it's as a research topic. I've struggled with how to manage a lot of conditions in the ED, especially these non-specific conditions like abdominal pain, where we do not have good clinical decision rules, we don't have a heart score, where we don't have great biomarkers. And thinking of how we best manage that, I've sort of come to this as maybe this is the best way that we should be doing this, and trying to do research around, all right, are we able to optimize care with this approach? And that's sort of why I'm here. So.
Hi, I introduced myself as an EMS researcher, but I'm really focused on sort of pre-acute care and the questions of like, do I need to go to the ER? And from an operational standpoint and implementation and research along with it is, like how, like not the level of doing a CAT scan, or maybe of thinking about that, but with much less information than you typically have in the emergency department.
So I think it's both for me. My academic interest is syncope, and that's an area which I think we need to bring a bit of shared decision making into. And I probably lied a bit when I said we don't do it in our place, but I think we probably do it on occasions, but we don't do anything that's formalised. We don't teach it, and yeah, we probably don't put the name shared decision making to it, but obviously we do discuss things with patients, but I think probably we don't know we're doing it, or we don't teach it, and we could do that much better. So from both sides, academic and clinical.
Eric's a better doctor than I am, so I come when he talks.
No. I think that teaching it is something that's important to standardize it in a way, because you work with residents and other people. Someone might say, we had a shared decision-making conversation, but what does that mean to everyone, and how can we get on the same page and not be redoing that work and invalidating what someone else might have said to someone? Something I'm interested in.
For me, I think it's kind of twofold. I'm sort of the advocate for patient and family-centered medicine at my shop, and I'm the one sort of saying that often. And I follow some of the research that's been out there, and so it is sort of being the advocate for my group and our other faculty, and also for the residents. But we also have a really strong advisory group, and we've done a lot of research with my patients and family members. And so this is something that we were thinking about maybe using as a topic for one of our goals as a council.
Oh, it's for the recording, so we do want to do this. Okay, so our objectives, we wanted to have it a little bit unstructured so we could kind of cater to your individual needs, which is why we just went around to ask kind of what angle you were most interested in. But just very broadly, we want to kind of describe and define what shared decision making is, what the key elements are. And then we actually want to do a little bit of role playing. So we will be asking for a volunteer, for a brave soul. I know it's always a little nerve-wracking to volunteer in front of a group of strangers, but hopefully somebody is willing to play the game. And I will be the patient, and I even have a patient gown to help everybody get into character. So we're going to do a little bit of role-playing, and then if we have time at the end, we'd actually like to pair off. Since we're a small group, we could probably pair off kind of one-on-one, and some people will do a little bit of doctoring, and some people will play the patients. And then we're going to, well, actually, kind of that's the last bullet, is to learn how to use it in practice. And then we can have a discussion a little bit about some kind of practical tips, something we talked about yesterday about how to do it, something that you might not find in the textbook or in the paper, but that you would only learn by doing it, many, many times in the ED. Okay. So what is shared decision making? I think everyone seems to already know what it is intuitively, but maybe we'll just go over a definition. But it's an approach, you could say, where the clinicians and the patients are collaboratively discussing different care options. And it's kind of key that there's got to be more than one reasonable option. You wouldn't offer something that was completely unreasonable or far too high risk. Maybe to use a quick example, you wouldn't offer discharge for a patient who's having an acute STEMI, right? Most of the time. And then, so you kind of want to reach a decision together, and there are a few elements that are going to come in. Obviously, the medical evidence and kind of your own clinical experience, but also the patient's values and preferences and kind of their social circumstances are going to come into play, which is not always what we were taught in medical school. So there's a lot of data that's been published around shared decision making across the House of Medicine, and then there's a couple studies that have been published in the ED. But generally speaking, the consensus seems to be that if you do share decision making, especially in a structured setting with a decision aid, you're going to increase patient knowledge, increase the comfort and the understanding of risk. There's going to be greater participation, more communication, and there's some data that suggests that maybe we're going to do a little bit less in terms of testing and treatment after doing some shared decision making. So this is a little conceptual model, if you will, that we worked together on, and we wanted to try to boil down shared decision making to its simplest elements. And really we came up with 3 very simple criteria to help the clinician determine when is shared decision making appropriate. And so it's a very simple flow chart. So basically you've got your patient and your doctor, that's your dyad, if you will, and then you ask yourself, well, is there more than one reasonable option here? And if the answer is yes, then you should ask yourself, is the patient willing and able to participate in the decision making? Obviously, if they're drunk or altered or severely demented, they may not be appropriate to actually have a discussion. If they don't have capacity, you wouldn't do shared decision making with them. But let's assume that they are able to and they're willing to participate in the decision making. Then you would ask yourself, do you have enough time? And I would say generally, the majority of the time, we do have a couple minutes to stop and go to the bedside and talk. But we are also, of course, emergency physicians, and there are some kind of hyperacute, time-sensitive emergencies, maybe a tension pneumothorax, to use an example. And in that scenario, you wouldn't want to spend 5 minutes talking about, do you want a chest tube, or do you want the needle decompression here, or do you want to just do it here? You know, you just act. So that's kind of our basic framework. Are there reasonable options? Does the patient have capacity? And do you have the time to do it? And then, so is this still me, Hemal, or do you want to take over here?
I'm happy to, but basically that framework sets you up for the actual process. So oftentimes something that gets overlooked, thank you, is actually just calling out that there is a decision to be made. So in the clinical situation, when you're meeting with a patient, just recognizing that there's a decision. Sometimes in clinical practice, we don't sort of call that out, and we don't sort of sit down and say, Elizabeth, okay, now we had to make a decision together, and just call it out like in that way, whether it's disposition around staying in the hospital or going home, or around a test, or the decision to go to the emergency department, for example. So calling it out. The next step is really then going through the different management options. So, for syncope, if you're talking about disposition, you've called out the decision around, there's 2 options, discharge or admission, and then you walk through really what that means. What are the pros and cons of each option? What are the potential risks and potential benefits of each option? And I think that's important because each patient and each of you have different values and preferences. So you're going to value things differently. Being at home for some people means being with their children, being with their pets, sleeping on their own bed. But maybe for other people it means, I don't know, I don't have a doctor around me, and I'm concerned if something could be going on. And different people value those things differently. So you sit with the patient and you explore their values and preferences and their individual circumstances. And some of the decision aids we have can go into detail about sort of the risk probability of different options. It can go into, for CT imaging, radiation, and cost, and length of stay, and sedation. And for others, there are not always all those domains known, or the risk probabilities are not known. And then really you're working together to make the decision together. And you as the clinician support either decision because there's no better option. They're both reasonable, and I think oftentimes one other thing that I try to add is making sure the patient knows they're supported in whatever decision. You're not asking them to make the decision for themselves. You're asking them to be engaged to the extent that they want to be engaged, and you help to the extent that they want to help. Anything else from the team here?
I think that's it.
All right.
Doctor. Who wants to? All right, Michelle. Excellent. All right.
That looks great.
Thank you. Is this
He did. He brought it down. It's very cute. Dr. Lin, why don't you come sit over here? So let me tell you about your patient. Did I just totally put down that thing? All right. We have some of it up here. So Mark is a 52-year-old male with chest pain. He comes to the emergency room. He's had chest pain for a day. His pain is intermittent. It lasts 20 to 30 minutes. His last episode was about 2 hours ago. He has a history of hypertension and high cholesterol. He lost his job a few months ago, and he's been looking for work, and things have been a little stressful. He has some good family support. He can't really tell if the chest pain is causing anxiety or if anxiety is causing the chest pain. It's not totally clear. Doesn't seem to be related to exertion or food or anything else. He does have a doctor. He's been taking his medications. He said they checked my heart last time I was there, and it was fine. He's mildly hypertensive, and he has an EKG with nonspecific changes, and his troponin is normal. So one thing is that we will, for the people who are doing this as educators, we can email these to you, and we have them. So this is something that you can then take and do with other people. And so he's our patient. We're going to have a conversation. For this patient, we intentionally made him not 100% low risk. He's not 22 with chest pain, and you're going to send him home. And he's not 65 with exertional symptoms. So if you were going to give him a heart score, you'd probably put him not quite in the lowest group, but exactly right above that lowest group. So we'll say he's a 4% chance of MACE in 30 days if you're a person who really wants numbers, remembering that our patients don't always understand the numbers that we have. Thank you, brave soul.
So I'm supposed to
You are supposed to, let me give you this, Mike, you are supposed to pretend that he is your patient and talk to him like you would.
Okay.
And he doesn't know his results of his tests yet. So.
Okay. Hi, Mark. It's Dr. Lin again. How are you feeling?
I'm feeling a little better than when I first came in.
Okay, good. I'm glad to hear that. So I have some news for you. We got your test results, and it's good news. It's normal.
Great.
Yes. So that's very reassuring.
So I haven't had a heart attack?
You have not had a heart attack today. That's correct.
Thank you.
Yes. And while that's good news, one of the things that we want to think about is do the symptoms that you've had today indicate risk for potentially having a heart attack in the next 30 days. So just because you didn't have one today, which is very good news, it doesn't mean that you're not completely protected from having an abnormal heart rhythm or a heart attack sometime in the future.
So it could still be a heart attack?
No, I think it's very unlikely, given the test results, that the symptoms that you had today were a heart attack.
Okay.
But, you are 56, you do have a history of high blood pressure and high cholesterol, and your EKG was not totally perfect. It did not, again, show any signs of a heart attack, but because you have these risk factors, we just want to make sure that we're doing the right thing for you.
Okay. What do you mean by risk factors?
Things that make it more likely that you might have a heart attack.
Okay.
Right?
Like
someone who's older or someone who has high blood pressure might be more likely to have a heart attack than someone who doesn't have those risk factors. Okay?
My dad had a heart attack.
Yeah. And so I think, that's important information for me to know, because I think now we have to decide whether you're safe to go home or whether we need to keep you in the hospital for some more observation and potentially more testing. And so it's important for me to know that your dad had a heart attack. Are there other concerns that you have about your symptoms today?
It was really the heart attack I was worried about, because my dad had a heart attack in his late 50s. He was also a stress pop like me. So just want to make sure I'm not going to die.
Yeah. No, I think that's very unlikely to happen today. Can you tell me about what else is important to you when you think about your health care?
Well, I want to be able to provide for my family, to go back to work, and care for my kids, my wife, and just live a functional life.
Yeah. And I ask not because I'm particularly concerned, but just so I can get a sense of what your situation is. But do you currently have health insurance?
Yeah, I have health insurance through my job.
Yeah. And where do you usually get your medical care?
I have a primary. He's over in Brooklyn.
Yeah, and do you feel like if you were to call that person, today or tomorrow, and they will squeeze you in for an office visit in the next week or so?
Yeah, probably in the next couple weeks, 1 to 2 weeks. Yeah, that's typical for them, yeah.
Yeah, okay. I mean, so given your circumstances, I think, we could go either way on
Okay.
whether you need to stay in the hospital or not,
Okay.
right? And, each choice has different risks and benefits.
Okay.
If you go home, you'll be in an unobserved setting, right? Something could happen to you and we wouldn't know. My hope would be that you are able to follow up with your doctor and they're able to take over your care from here, but that's up to you. Based on everything, I would say, that approximately 1 in 25 people like you might go on to have an abnormal heart rhythm or a heart attack in the next 30 days. I know that's difficult to conceptualize, but I just wanted to give you a sense of the risk of something bad happening.
Okay. So I'm low risk, but not zero risk.
Yeah, and I don't think we ever actually have zero risk or 100% risk, right? So
Okay.
your risk is low.
Okay.
The other option is for you to stay in the hospital, that's potentially expensive. They might expose you to healthcare-associated infections. It's a little loud, hard to sleep, and I don't know if you have to work tomorrow, but you'd have to call out. On the other hand, the benefit would be that we can do some repeat testing to really, really make sure you didn't have a heart attack, potentially do like an ultrasound of your heart to see what your heart functions like, and all of that information will help us be able to really tailor your future treatment options a little better.
Okay. So hold on. That was a lot. Let me just see if I understand. So you're saying I could go home, call my primary. I could stay and get a lot of tests and stuff.
Pretty much.
And, what would you do if you were me?
It's hard for me to say because, my risk factors are different from yours, I like sleeping in my own bed, and that's more important to me, but you're telling me that, you care about being able to work and that you're concerned because your dad had a heart attack, so I want you to think about those things and not necessarily what's important to me.
Okay. But it's safe to wait a couple weeks to get all these tests you talked about?
I think so. I think the evidence suggests that, as long as you are able to follow up with your primary care doctor, there's not like a specific amount of time that you need to get these tests done within.
Okay. In that case, I would rather go home.
Okay, great.
Yeah, I'll come back if I get the chest pain again.
Yeah, that sounds wonderful. Okay.
Great, let's do that.
First, Dr. Lin, how was that for you? What would you like to say about your experience?
Obviously, it's a little artificial.
Yeah, it's like super awkward, I think. But actually, it wasn't as awkward as I thought it would be because I think I just go into clinical brain. I thought that was good. I don't usually get as many questions, and so it's good to be pushed a little bit to think about, how would I explain that? I think I do get like, what would you do? And again, like, I don't know. And then sometimes I even feel like, maybe I should recommend something, but then I really want to fish for your preferences. So I don't know. But I felt like you kind of knew what you wanted, so I was waiting for you to declare that.
Right. And shared decision making has been called an awkward dance. I think you wrote that in one of your papers. And I kind of like that.
Other things are awkward, but not that too. I feel like a lot of times that people want permission. I feel like a lot of times they'll be like, well, these are the two options, and then they'll kind of hint they want to do one thing. They hint they want to go home, or hint they want to stay.
Right.
Well, that's a really, that's a great idea. Why don't we just do that?
Right. They kind of want permission. Yeah, they even want permission just to be involved in the decision. So as soon as you open it up, then you'll start getting more questions from patients. Sorry, but
what are your thoughts? No, what are your thoughts?
Obviously, my health literacy is probably a little higher than the average patient, so I was trying to, role play. But I felt like there was a lot of information coming at me, so I was trying to kind of slow down and recap and simplify for myself. But I like how you didn't kind of push me in any one direction or another when I asked what would you do, but it sounded kind of like you set up some conditional statements, like if X is very important to you, then maybe this option is better, talking about work and sleep and so on. But other than that, I thought it went well. This is probably more of a conversation than most chest pain patients have when they go to the ED. And I don't know how long that was. Was anyone timing that, or? Okay.
because in a session like this, we've got a lot of time, and in a real shift, you're feeling pressed, so you don't always have that luxury. But maybe we could open it up to the audience and get feedback.
I do think that if the way of learning things is do it slower, right? Do it slower and in controlled settings. I think it's fine that it takes longer now, and then we sort of get better at it. But what does everyone else think? What do the participants think? What would you have done differently? What did you like? What do you do differently when you do it?
So when I do it, which I try to do it often, I think what has helped me at least, or I feel like my patients kind of understand and connect a little faster, is I sort of lay out the framework before I go into the discussion. So I kind of say, hey, so I give them the results of whatever the tests are, and then I said, I think we're at a point where we have some options now, and there's really no right or wrong answer. We just have to figure out what the best answer is for you, and then depending on what I feel, but most of the time I will actually bring it as if I can, and I know the answers to these things. Is I'll attach a little bit of statistics as much as I can to them, because some people, again, my patient population is probably different than other people's as well, and so if I think they understand and they can follow and they want that information, I have people who ask me all the time, so what % of chance, and I try to figure out their risk percentages and things like that. But I'll say, option A is this, and option B is this. Then I will actually say, choice 1, we can do this. Choice 2, we can do this. Choice 3, we can do this. And if you do this, this is what it's going to look like. And if you do this, so I kind of actually stepwise it for them. It just helps them wrap their head around it, I feel, a little bit better, as opposed to just a sort of open-ended dialogue. Because then we get to the end of it sometimes, and I feel like they're like, okay, so what are we doing? And then kind of go back to step 1 if we don't do that. So I've noticed I tend to do that a little bit more.
We're a bit spoiled with visual aids on our department right now for chest pain. It's wonderful. Yeah, and I think it helps so much for patients, because it's a long conversation. It's hard, kind of as you said, to make sure they're connecting from A to Z as you were. And I think at the end of the conversation, you're like, oh, wait, so say that again. And if you have the aid in front of you, it's a schedule.
And standardized, organized, yeah. And some people are visual, and seeing, 4 red people with 96 blue people is easier to kind of understand.
I mean, some of the power of those formal decision aids are that they present, when risk is known, they present the risk in multiple different forms, and some people may respond to, 1 to 25, some people would respond to the red and the blue, sort of pictograms, but some people, when you say 4% chance, and people respond to different things, I think that's one of the values of those formal decision aids, is presenting risk in different formats to capture as many patients as you can.
I just want to add, for those of you who are interested in bringing this to your shop and teaching people some of the, and just maybe share very briefly just some of our experience with doing this, is it's really helpful to give people the framework. So we do a very short PowerPoint, or we actually do it asynchronously, where we send them a paper to read about what does shared decision making look like in the ED. We do the very quick PowerPoint to say, and then we kind of leave up the framework to say, especially for learners, so we've done this with PGY 1 as well as PGY 2 and 3, the junior learners really need that framework. And it's very helpful for communication skills to be able to model the conversation. I know nobody likes role play because it makes puts people on the spot and makes people nervous, but demonstrating how how it's done well, and you can even do 2 different conversations where you do one well and you do one sort of not so well, and then have a discussion about that. Just having to go through and communicate each of the elements just makes it easier when you actually have to do it as a patient. So I would really encourage those of you, if you're going to bring it to your shop, not just give them the framework, but actually demonstrate it and then make people go through it, just like we're going to do.
So we purposefully, for this one, right, we didn't give Michelle and Mark the chest pain choice decision aid. I think it's equally important to have example situations where you're using a formal decision aid, and then also when you're not using a formal decision aid, because realistically across the country, most people are doing this without a decision aid, but there's still ways to
augment your communication skills with your patients that are evidence-based. So practicing with your trainees with multiple different types of cases, which is basically where we're going to go with the rest of the workshop.
If there's like a set 5 or 6 conditions that you find you're using all the time, or is it something you use for everybody? Although I know symptomatic brain doesn't really need a...
Well, so we have some data from both directions. We have data from when we ask doctors when they use it, and then we also have data from when we ask patients to try to share decision making and what was it about. From the patient's perspective, it was most frequently about discharge versus admission, not specifically for chest pain, for everything. And when you think about it, and when I sort of speak anecdotally, we do have a lot of conditions where maybe the pneumonia is borderline, or maybe there was some weird neurologic thing that's gone now, and you sort of don't really know if they need an inpatient workup or an outpatient workup, and so you involve them in the decision. And those ones, especially the weirder ones, are the ones that they'll never be decision making for. And so that's one of the reasons to get good at it with as much help as you can, so that you can then extrapolate. And then after that, it's usually the advanced imaging using CTs for things that are sort of non-specific, and what we come after that, treatments, essentially medications.
I mean, I would say the more, like, after hanging out with this crew of people and doing research on it, then I find myself in my clinical practice integrating it all the time for all types of things. Like, do you want, medications orally, or do you want an IM injection? So it's definitely, like, there's not decision aids for all of those things, but it's almost, it just seems like the right thing to do to engage patients if they have, different preferences around really basic things, because we're making decisions on their behalf all the time about what, to get labs, what labs to get, et cetera, and you do it to the way it's practical, but I think there's a lot of opportunity beyond what has been studied, and in emergency medicine with evidence beyond it.
I found that the admission discharge is when I frequently use it. In my last shift, there was a patient who had isolated hypoglycemia with no diabetes, and as I could tell that they had sort of limited resources. Like I said, if I give you a prescription, will you take your medicine? Do you have a doctor that can actually see you to make sure this doesn't turn into DKA? And ended up actually providing their home prescription for them, contracted they see their doctor within the next week, and discharged them, or otherwise, like if they didn't have any of that, it's like, I just don't feel comfortable sending them home. But that would be a pretty common scenario that I just, on the fly, you just kind of figure out what are the factors that would influence the decision and get the patient engaged in the thought process.
Yeah, I mean, for me, a lot of these examples seem like we're sort of just navigating areas where there's no right answer. So you're just sort of trying to say, what's the best way to do this when we really don't know the best answer? So we give the options and we elicit values. I mean, when I think about, for me, the best example that I use it in now is with appendicitis, because we clearly have data where there's 2 options, and if you want to do some people are just scared of surgery, and that's such a great time to and some people really just want antibiotics, and we have the data. And
over treatment.
Yeah, over surgery.
Yeah, right. It's also
and we know the numbers. If you're less concerned about it coming back, because we know there's recurrence rates, I really like using it for that kind of thing there. I mean, for this, I think it makes sense, but for times when there's really just 2 options where you just need to elicit values to figure out what the patient wants, I think that really works. What I really want to learn is because I found that interaction really unrealistic. For an ER visit, I mean, it was great for an interaction, but there's no way we can do that, I don't think.
Because of the time?
The time, yeah. And I think I'm good at explaining options, or telling there's an option. I'm good maybe at describing what the options. What I'm not good at is eliciting the values. And I don't know if you guys can give me advice on how do I quickly elicit values that help make that decision without having a really long conversation. Getting to know this person more than I've done.
That's a great question. I think that's where a lot of us get tripped up. I mean, there are some kind of standard, generic questions that are a good place to start, and then you kind of have to just see where the conversation goes. But the standard, generic ones that come to mind, I'd love for anyone else to chime in. But what were you most worried about when you came to the emergency room, or what were your main concerns?
Yeah, I will say, I straight up say, so I've told them, I've laid out that there's a choice, I've told them the two options, and I've given them some information about the consequences of the options, not extensive, because you could just keep going forever down both pathways. And then I immediately want to get into what do they think about those options, so I straight up say, what do you think about those options? And then they will gravitate towards asking you questions about an option because they're worried about that option, but they're interested in it, or they want to know more about it.
So you're not doing the things like, so tell me what's most important in your life.
No, because, so this is the thing that kills me about the research. The research says, find out your patient's values. And like, if you say, well, tell me about your values, and the patients are like, sorry, what? So you have to just be
It's a hard conversation with your good friends.
Yeah. What do you think about those options is find out about your values, and it works. What do you think about those options? Well, I was hoping to go home today. I'm glad that you think I'm not having a heart attack. And you're like, okay, so we're starting to go in that direction. You understand that there's a little tiny bit of risk with that? Yeah, it sounds like it's a really small, and I like actually the way that you said it. So it sounds like you're not 100% sure, but a very low risk. And I think that sometimes is better than the numbers anyway. But I think that to get quicker to, it's like, what do you think about those choices? And if they really are not sure, that they will ask a question at that point.
Yeah, it'll come out kind of implicitly through the conversation, through the dialogue. You'll just as an emotionally intelligent person, you'll be able to kind of sense what their values are.
But I would suggest it straight up to ask.
Yeah, and I would say the question like, what is your most biggest concern today? And then if that doesn't get to it, what were you hoping to do for you today? Right? Gets a little bit closer to it. And then giving them time, right? Because I'll say oh, what do you think of those options? And they're like, I don't know. No worries, you take your time to think about it, go see another couple patients, come back in 15 minutes, and be like, all right, any updates, any questions, and that way it's not a ton of time in that room. And then with the where do I use shared decision making? Honestly, I think about what is going to be potentially most harmful or most costly to that patient, right? And so that's going to be admission decisions. I don't spend as much time talking about lab tests, whether or not to do IV tests, because I don't have that much bandwidth. So I try to think about it that way.
Yeah, but I think that's a really good point, because oftentimes the patient is going to look at you after you've laid out the option and say, I don't know, what do you recommend? What would you do? And sometimes that little timeout, be like, well, why don't I just give you, a couple minutes, think about it on your own. I'll be back. There are always small tasks you can do, 5-10 minutes. Chart on one more patient, and then come back. And oftentimes I found, this is purely anecdotal, but I found patients kind of go towards one direction after being alone for 2, 3, 5 minutes.
I also want people to realize that Dr. What Would You Do is not a fail. You did not fail at shared decision making because they want your opinion.
Is it still shared decision making?
Yeah.
Well,
did you fail if you
give your opinion?
And neither. So I will tell you, I'm going to tell you that there's an evidence-based answer for what to do about your opinion. They came to you because you have expertise. They want your expertise. They want to know that you don't think they're having a heart attack based on your expertise, and they also want your expertise of what to do next. Now, that being said, you could say, well, I need to do this, and that doesn't really help. And it could be shared decision making, it could not. It depends whether they feel empowered to disagree with you. And to me, it's shared decision making if they feel comfortable making a choice that's different from what you just told them if you chose a choice. So if you refuse to give them any opinion at all, to some degree you're doing a disservice if they really want an opinion and they're really in the middle and you haven't been able to figure out what's best for them. So if you say to them, well, from what I've heard from you about what's important to you, this might make sense, but other people say this, and it leads me to say this makes sense. So you've just given them a little bit of an opinion. From what I know about you, this makes sense, but for other people, this makes sense. And that opens the door for them to say, yes, I agree with you, that does sound like me. Or say, oh, that other thing that you just said about other people, actually that does sound like me and I'm going to go in this direction. And so you have supported the idea that you are truly okay with both options, but your expertise leads you to think that maybe you should go in this direction.
If all the people in here who are experts on it saw the interaction, would everybody agree that was shared decision making and that wasn't?
No.
Not necessarily.
There's not good tools.
You can't say if it happened or not.
In emergency medicine.
Yeah. There are some research tools. I don't know if you want to talk about research tools, because there are some measurement tools that have been developed to measure the quantity or the degree of shared decision making.
Like the success of it, but...
Yeah, there's option 12, the option 5, which is basically you have to listen to the audio recording, and then there are different criteria, and you get scored from 0 to 4 on each one. There's a collaborate questionnaire.
Though some of these are not from the patient's perspective. So something that a researcher looks at and says, that is perfect shared decision making versus something that's imperfect shared decision making. patients may see the same way, and they may feel valued, and they may feel they have their voice heard, and it may be the same thing to them.
I was just going to add again, to one of the questions was around, so if the conversation doesn't go anywhere and they want you to make the decision, is that a fail? No. I actually always offer to make the decision for them, too. Like if you don't know or you don't want to be involved, I am happy, or you don't responsibility, I'm happy to make the choice for you. And that's that's built into a lot of the actual formal decision tools as well.
Do you want to be making this choice, or do you want us to do it?
I like to wait a little bit before outlining that. I want to put a little bit of pressure on them to think about it, because I don't want to let them off the hook too soon. But yes, ultimately, that's always the kind of the escape valve is I can make this decision for you.
And the other point you made about like this being unrealistic, I think there's components of it. Of course, we're in a whatever building. We can have some more time here. I will say, like, time-wise, I'm not convinced personally that it takes more time to do it. And just again, there is some evidence that it reduces aggressiveness of care. I don't think that's the reason to do it, but if you think about spending that, 5 minutes, less than 5 minutes, and that individual Mark in this situation goes home instead of in another situation, is admitted, boards in your emergency department. So I'm really not convinced that that a couple of minutes of time is a huge barrier.
Yeah.
I was going to say, just to that point, I meant to say that earlier, one of the things that, to give you a specific example, is using sutures or Dermabond. I always made the decision for people, always. And then my daughter, who was 3, had a cut, and I went to the ER at Disney World. And I, went in as an ER doctor, but so I knew everything, and I very quickly said, no, we're going to glue this. And they're like, no, but it was on her face. They're like, but she's going to have a scar, and she's a little girl. And I'm like, I understand. We're going to glue it. But I could make that decision very confidently based on my knowledge and things like that. And I went home, yes, she had a scar, but I think she would have a scar regardless, right? And I know that. And when she's older, she can decide if she wants to get it minimized. But that was my decision as a parent to do. And so after that encounter, I started realizing I need to, let people understand the choices that they have, especially with kids. And because we often, even with kids, we see quite a bit of kids, and so we actually sedate them for a lot of that, and that comes with a lot of risk too, right? So I have, the amount of gluing I do now, and I tell parents they will have a scar. It might be worse than if it was, it has to be an appropriate last that I do it, but that, literally I've changed my practice 180 degrees for that example alone, and most of the time they pick the Dermabond, which reduces my length of stay significantly as well, so it definitely can work both ways, and that's not the reason to do it. And then of course I still have patients or parents or even adults who say, no, I still rather do the sutures, and that's perfectly fine. But that was just an example that came to mind as far as time goes.
I feel like it definitely can take forever, though. I had a patient the other day who, had, I forget what it was, but something, kind of a soft admit, and I spent 15 minutes lady, you're talking in circles, stop. And I feel like a lot more to the point. What was that?
That's what I page myself.
Well, I feel like kind of what I've started doing is just being direct. I say, hey, why are you here? And, oftentimes, the residents are kind of afraid to ask that, but they'll come back and say, oh, I just want to make sure I didn't have a heart attack. Oh, that's all you're worried about? Cool, then I think you can go home and get a stress.
And I've started making this take the whole encounter. So when I first see someone, mainly with chest pain, because that's the most algorithmic, I'll say hey, we're going to do some blood tests. I already have your EKG. You're not having a big heart attack. We'll look for a small heart attack. I'm going to make sure it doesn't seem like it's anything else. And then we're going to talk about your risks going forward and what we should do.
I think that's great. And then we're going to talk about it.
And then I come back 30, 40 minutes later and I say, your blood work looks great. And they say, awesome, I just want to go home. And you're like, all right, cool. Let's just talk about that a little bit more.
So you planted the seeds right from the initial interaction.
Just do a little inception. Just make make that decision before you give them.
As a researcher, I was wondering what you guys think is the most important primary outcome, because you mentioned 6 different effects, and since we have to sort of plan our studies around the one that's most important, for me it's aggressiveness of care, but obviously for you that was, I heard you mention that it's not about aggressiveness of care. For you maybe it was about, maybe a little bit about aggressiveness of care, but so can you go back to the slide with all the potential outcomes?
Yeah, and there's a healthy discussion around that. What's the best primary outcome?
And does it fail if it only does one?
We could relay the
didactic if we go this direction.
Yeah, actually, we only have about 10 minutes left, but I mean, you could do patient
Our
knowledge.
education person says it's okay for us to talk about to talk about emergent themes.
Right, yeah, no, you could do patient knowledge, you could do utilization like admission rates, stress tests. You could do things like actual measurement of how much shared decision making occurred using, say, the option 5 score. I think it kind of depends on what your agenda is and what your kind of long-term research arc is.
I think there's a couple things to think about. On the one hand, we think shared decision making is good for patients, so I feel pretty strongly that we need to measure things from the patient's perspective, which is not option 5, but make it collaborate, right? Because collaborate is like, did you feel involved? Were you involved? So it's sort of patient satisfaction-y types of things. On the other hand, I'm very pragmatic, and I'm well aware that our physicians don't actually care that much about patient satisfaction because of all the other things that go into patient satisfaction. Yes, we want our patients to be happy, but there's a million other things that are as or more important than patient satisfaction. So if you publish a paper that said, look, I increased patient satisfaction, people say, well, that's great, but they don't necessarily say, well, that's important. So I think that for the physicians, you need to figure out what's important to the physicians, but the problem is the physicians are also all over the place in terms of what's important to them.
Yeah, it really depends which angle. Are you a patient, are you a doctor, are you an administrator? So I don't think there's
Right, the length of stay came up a lot for us because we're now at a place where we're asking our physicians about this and what do they want out of it. And a lot of they want to make sure people are bouncing back. That we revisit specifically.
Can I ask a question? Is there any negative research in terms that you're aware of that kind of shows concerning for like litigation? So like there was a shared decision that went bad and that kind of thing. Is there stuff that will come up in that realm?
We are aware of 2 studies. So there was one study where they did a hypothetical jury sort of study, and they basically had jurors say there was shared decision making, and this was about prostate. And they basically said that using a decision aid was protective in litigation. And then the only other study we just did, and it basically, we used potential patients, and we gave them vignettes. One group of patients got a vignette where there was no shared decision making. The doctor just said, you know what, everything looks great, you don't need a CT, you probably don't have appendicitis, come back if you have a fever. And they gave them good discharge instructions. And then the second vignette, the doctor said, you know, you probably don't have appendicitis, we have a decision to make. You could get a CT scan, you could come back if you get worse. And then so it's shared decision making, but we called it brief. We originally called it realistic shared decision making. And then the third one, I think what I called extensive or thorough or something that was like unrealistic shared decision making, where the doctor says, these are our 2 options, and went through sort of all the downsides and plus sides of a CT. And then in each vignette, it's set. And so the patient doesn't get a CT scan, but it's like who made the decision? The doctor, the patient, and the doctor together, and the patient and the doctor together. And then they concluded the vignette, which is that you had appendicitis, and it was ruptured, and the surgeon said, hey, if we had picked this up earlier, you wouldn't have had a bad scar, you would have missed less worse, that sort of thing. So we made it a negative outcome. And the people who read through this then were asked whether they would consider suing, and the rate of considering suing was dramatically less for the shared decision-making groups. And then more importantly for me, the secondary outcomes were consistent. They trusted the doctor more, they rated the doctor more highly, they were more likely to say, hey, this happens, it's not the doctor's fault. Like I understood that this was something that could happen, and it happened, and that's okay, and I was part of the decision. And so I don't know that we're going to have better evidence than that, just because it's really hard to study lawsuits. I thought you were going to actually ask, are there downsides to shared decision-making? And I would say that I think it probably increases decisional conflict. So decisional conflict is the idea that I don't know what to do, and there's all these shared decision-making studies trying to see that it decreases decisional conflict. And in the context of the emergency room, when we have not given patients any decisions, and all of a sudden we do, I don't see how it could do anything but increase decisional conflict. So that's on us. We have to figure out how to not make it increase this decisional conflict. So I'm not measuring decisional conflict.
That's a bias.
Yeah.
Do you document what you do in any other way differently? So, for example, I might put patients say not wanting something that I feel they should have, and then making that decision. I'll go to lengths to say pros and cons to discuss. Patient has capacity, blah blah blah. Do you mention shared decision making, or how do you?
I don't have a template. Some of my residents actually have like a template for shared decision making. So shared decision making around chest pain, pros and cons discussed, patient decided to go home. So it's very, some people just write shared decision making around this. Decided to go home.
I have what's called a smart phrase. So we use this EHR called EPIC, and the smart phrase is .SDM, which is very easy for me to remember. And then there are some blanks that I fill in regarding the options and then the final consensus decision. But the title of the note is Shared Decision-Making Note. I don't know if that has any benefit.
And I will say, I've seen it in charts on people who bounce back, and then when I ask them what happened, and they tell me about it, and it's definitely not shared decision. Like, the doctor told me I didn't need a CT scan, I didn't get the thing. So
Right.
It's shared decision making about whether.
I think that's a good point. Everyone thinks they do it.
A lot of people think they're doing it just by communicating and then telling the patients what to do, but it's way more than just risk communication. It's a genuine offering of two options.
Right. And I think that if I could stress anything, that first step, choice awareness, I think that that's the most important step. You can't have anything else if you're not aware that there are two choices.
I mean, how much of that's hindsight bias? I mean, obviously it's a hypothetical, when you did your study, whereas this, the patient bounced back and didn't get a CT. I mean, if he didn't have appendicitis, oh yeah, we talked about it, I don't have appendicitis. If he did have appendicitis, the doctor told me I didn't need a CAT scan.
It's very, we know from other studies that like what we say is not always picked up.
How do you document it?
Well, we have, for our chest pain patients, we have a standardized documentation, a smart phrase, depending on the low, intermediate, or high risk. It's very similar to what you guys described. Sometimes I'll engage patients in a conversation, and I clearly don't want them to go one direction. And when they choose that direction, that's when I'll go into the values. I kind of like let the values just kind of implicit with their choice for efficiency reasons until it's like, wait a minute, that doesn't sound like a good decision. Why? What's driving that direction? And you may figure out some other issue that you can solve by getting a social worker involved or getting a family member involved. But if they still make that decision, I don't ever do AMA. I just say I discuss risks and benefits to the patient. The patient understood that they could die, or like the worst possible case scenario. The patient declined. And just leave it at that without turning it into an adversarial. Just be
I think that's
factual about it.
a great segue. So I would add, in terms of like all these scenarios where we use shared decision making, is that there's scenarios where there's, from our perspective, there's not equipoise, and shared decision making is still appropriate. And I would use Suboxone as an example there. You see a patient that just overdosed, and you are assuming you're X-waivered and you can start Suboxone. We know from a medical standpoint that it saves lives and that they should be started on Suboxone, but you can't just write them Suboxone because adherence is more important than you handing them a prescription. So the conversation where you say, hey, we have some options here, and one option is, you can go follow up with your doctor and regular, and the other option is I could give you a prescription for Suboxone and a piece of paper that talks about how to do home induction and that sort of thing, and here's the benefits of this one, and here's the risks of this one. And like, there's no medical equipoise there, but the fact that you presented it as an option gives them a chance to feel in control of the situation. And the other thing is it lets them enunciate the reasons why they're going to go one reason or the other. Whereas if you just give them a prescription, you have no idea what they're going to do, and you can't tailor it to who they are and what's going on in their lives and whether they'll do it or not. So I will say that there's, I think, opportunities for what I'm calling expanded shared decision making, which is using it in places where it's not sort of traditionally appropriate.
For the education folks or folks who are interested in this in their own shop, we probably not going to go through the rest of the didactic, but I would encourage you we're happy to share sort of the cases and running them with your trainees, and just going through simulations is a nice way to expose people, and then also hear, in our own experience, different barriers come up with interns that come up with compared to like soft boards or faculty members, and it's sort of it's been interesting for us to find a curriculum based on the level of the learner.
I think this was a fairly high level. This group was clearly very high level. So feel free to come and take these. One of these is the patient role, and one of them is the physician role, and we can email them to you if you want them electronically as well, just to use with your colleagues and learners.
You said you don't do AMA. So if you were giving an option where the option you didn't want was unsafe, that would be AMA. But that you would never do shared decision.
No, that's not. No, I'm just taking it to the following extreme where you're explaining to a patient, I think this is probably what's in your best interest. This is what I would recommend for these reasons. Does that sound like you're okay with that? If they say no because, and then they go that direction, I just make sure that they understand. Because I think the biggest risk is that afterwards they say, and you're charged, we gave them a choice, or we told them what we recommended they decline, and the patient can say, I never knew that I could potentially die, or whatever it was. I specifically state, so if they don't remember anything, that the worst case scenario is written in the chart.